Research Council's Biostatistics Unit in Cambridge. And in the centenary year of the Medical Research Council's Biostatistics Unit, we were delighted at Easter through to June to welcome Ronald Kagube, who is a lecturer in pharmacy at Makerere University and works at the Monago Hospital. I was asked by THRiVE if I would mentor Ronald's work on pharmacovigilance. He's done two main studies. The first of them I'll give you a little insight into. It was a survey of 1,345 healthcare professionals across Uganda, doctors, nurses, and others, about suspected adverse drug reactions and medication errors. These 1,345 respondents were 2/3 of those to whom forms were issued. His first study was about the incidence of suspected adverse drug reactions and healthcare professionals' attitudes to and reporting of those suspected reactions, both locally within their own hospitals and nationally. That paper has been accepted at the end of that visit to Cambridge in BMJ Open. His second, arising from the same study, concerns description of 241 of the most recently suspected adverse drug reactions in the past 4 weeks. So 241 descriptions from 1,345 healthcare professionals. Those 241 descriptions, ladies and gentlemen, are more than the National Pharmacovigilance Centre in Uganda receives in an entire year. The third paper from that study will be about attitudes to local and national reporting of medication errors, and I've left the responsibility for that to his local supervisors. But let me tell you about some of those 241 descriptions, including serious, rare adverse drug reactions, Stevens-Johnson syndrome, associated with HIV medication, in particular nevirapine linked, but also linked to cotrimoxazole. And amongst those 241 were, of course, a healthcare worker who was receiving post-HIV exposure prophylaxis, and she developed Stevens-Johnson syndrome. There were quinine-associated serious adverse reactions, a child fatality that was described by more than one healthcare worker, post-injection paralysis, which is a should not occur event, and miscarriage. There were coartem associated episodes of severe hypoglycemia, swelling of the face, and generalized body sores. And there was an instance of diclofenac associated hemoptysis, of which there have been only 2 case reports recently in the literature. What I would hope that THRiVE will leave for East African countries is a resource of study materials and analysis routines that can be adopted by fellow nations, so that Ronald's survey questionnaire of healthcare workers and his analysis routines could be adopted by other African nations to find out about their suspect adverse drug reactions. And a brief form has been devised for the description of suspected adverse drug reactions to be used prospectively in randomly selected months and wards within the hospital. And the analysis that is included in the second paper could then give prompt feedback within the hospital. This is a study method that has merit not just in Ugandan hospitals, but in UK hospitals too. Now, I won't say it hasn't been at times a bit of an uphill struggle, particularly in terms of accuracy. There's also been a slight difference in cultural approaches to rest and relaxation and to timekeeping. So that when we were trying to finalize the second paper at the end of a week in Mwanza, and I was hoping to have an hour off to go and buy a Tanzanite, unfortunately I did not have confidence that Ronald's sums yet added up. And so I suppose I have him to thank that my bank balance still adds up because no Tanzanite was bought. Ladies and gentlemen, let me turn now to the main purpose of my introduction this morning, which is, of course, of Cambridge's Vice Chancellor. As a clinician in infectious diseases, Professor Borishevitz had frequent short exposures in clinical practice in West Africa. And this was, for him, a formative experience. So that even now, Boris chairs a small foundation that seeks to deliver new drugs for the world's neglected diseases to patients who will never be able to pay the full costs. In an oration last year at Monash University, Cambridge's Vice Chancellor said, "Poor health, poor nutrition, and poor education all derive from poverty and are interrelated by poverty. And so what can leading global universities do about it?" He argued that the advancement of health, wealth, and nutrition in low-income countries is a wholly legitimate target, as well as a major academic challenge for the world's top universities. And, as he will show, we in Cambridge are uniquely well placed to make that difference. Vice Chancellor.